Ajeet Singh is an academic private psychiatrist with interests in complex mood disorders, transcranial magnetic stimulation, and pharmacogenetics. In 2013, he was awarded a doctorate in blood-brain barrier pharmacogenetic prediction of antidepressant dosing. He is a senior clinical lecturer and research fellow at Deakin School of Medicine and deputy medical director of the Geelong Clinic. Welcome.
Good morning. And I'm very pleased to be on the speakers list, but I'm very cautious that I don't see myself as the only expert in the room. The truth is, collectively, we've got quite a degree of expertise, and I think the value add I can bring is having probably an above average knowledge of the genomic space. The good thing about the genomic space is nobody knows it all, so be very cautious of anybody who makes out like they know it all. It is a great frontier with much promise that hasn't delivered in a long time, but that looks like it might be changing. There's a lot of technologies that come with much promise, oversold, over-promised, under-delivered, and to an extent I think most of us in the healthcare sector have been at times jilted by things not panning out. But at the moment there are a multiplicity of lead indicators that the space is going to accelerate, and I'm hopeful that the usual suspects alone don't win from the emergence of this new domain of medicine. Specifically, there's an initial focus on oncology, which is very important and a key cause of mortality in the world. But when one casts one's mind to morbidity, burden of disease, well, I think as psychiatrists and people interested in mental health, we're front and centre in that. And if there's opportunity that new technology can reduce burden of disease, it may actually be the case, pending enough evidence, the right kind of evidence, that psychiatry and psychotropics and our diagnostics, in part, might be enhanced by genomic medicine. But the good news is most of what you already know is entirely applicable. In fact, the stuff you already know is 95% of what you need to know, and it's whether this new science will actually enhance what we already do by reducing a little bit of the trial and error in both diagnostics and prescribing. My talk is going to focus mainly on genetically guided prescribing, which is the simple speak version for precision medicine. And I've got quite a few slides, but happily they're mainly pictures. And I've adjusted my slide set this morning at 5 a.m. So for some reason that wasn't updated in your handout. So I sent in the sort of alpha or the beta version a week ago, but I've always been a crammer. And I've decided to rebadge myself because people who are interested in things are zealous, and so I thought, okay, I'll call myself a psychiatrist and a pharmacogeneticist. So hopefully the zeal actually translates into better outcomes for patients, which is a thing that really should fundamentally inspire us all. Now, I've got quite a few disclosures. So through serendipity, I happened to do a doctorate in an area that's turned out to be commercialisable. So I've sort of looked particularly at blood-brain barrier genetic variants and their role for determining CNS bioavailability of various agents, including antidepressants. So all of a sudden there's all these companies from America and stuff emailing me and Skyping and stuff. And I have been offered opportunity to buy into companies. And so this does create a potential conflict of interest. I was offered to buy into a few companies, and last year I bought equity into a company called Life Letters. I have less than 1% equity through at arm's length trust structures, as my accountants advised. So I do have a very small conflict there, but my stakeholding is small. And that venture I bought into once they approached me to ask the question, how do we responsibly bring genetics to medicine? How should we not turn it into snake oil? And I thought, wow, that's the first time a company's approached me as that's their lead-in. Usually it's, we've found the answer and this is what you're going to do for us. So that's my formal disclosure. I've got the standard sort of speaking appointments. I've also, through serendipity, just by being in the right area, been invited to a lot of peak government and industry groups nationally and globally. And there are a couple of big ones. So there's the International Society for Psychiatric Genetics. So I'm on their writing group for international guidelines. And there's another one through Stanford University called the Clinical Pharmacogenetics Implementation Consortium. You can tell they're academics and not marketing managers with their acronyms, but that's the global peak body at the moment to try and guide medicine as to what the heck to do. Now, before I go, I might just through a quick show of hands, just get a sense of who in the audience would say they have a firm, clear sense of what to tell patients about genetically guided prescribing in psychiatry. So if you feel you've got a pretty firm understanding of what to say to your patients, don't be bashful, raise your hand now. Okay, good. So now make sure you ask me hard questions. And hopefully I'll have clear answers. So my simple measure of an expert is is somebody who can explain the complex in simple, understandable terms. So hold that to me, and if I fail, I'll Google it later and email the answer to you. Now there are some take-home sort of learnings so that it's not too nebulous what we cover, and that's a list of them, and they should be there. And the long story short is I'm hoping that the take-home learnings will enable everybody to answer that first question differently. That is to say, yes, I'm no expert in genomics, but as a result of the talk today, I feel confident enough in the clinical space to give some general guidance to my patients because they'll be seeking it from us. So in the Google era, we're not completely irrelevant. When my patients Google things, I say, look, it's good, and it's good that you're engaged in your healthcare and information is useful. And then I tell them about how I Google recipes, but I never know when to add that pinch of salt. And it really can change the outcome in complex recipes. And I think this is the truth, and that patients who do Google also will come to us out of respect to say, what's your impression? What's hype? How does it fit into the complex biopsychosocial mix of what I'm going through? So I think you still have a key role. And in fact, I'd go further. I'd say genetically guided healthcare is going to make doctors even more relevant than ever, particularly GPs. So I don't see this as something that's going to disempower medicine. I see it as something that will enable it. So I encourage you to embrace. In particular, I want to spend quite a bit of time going through the basics of genetics. So when we go to medical school, we get the basic stuff, but it has very little day-to-day clinical applicability. So therefore, we tend to have atrophy of our learnings. What's the point of spending time on something that's got little clinical valence to assist the people who attend for care? So I'm going to go through it quite a bit. The only dumb question is the one you don't ask, quite literally. And so ask, so that when your patients come, then you're the person who can give them some guidance and then know when to refer them to a website or more readings. I'm going to go through a little bit about the technology. So the reason that there's been a big time lag from the whole genome project to now is cost. So the first whole genome sequence done in approximately 2003, depending on the resolution of sequencing you look at, was $3 billion per person. So there's only a couple of Australians who can afford that. Now it's $1,000. Probably a few years from now it'll be cheaper than an iPhone. Now just think about that for a technological revolution. So it means that the price point is doable. Question is, why would you spend $5 on something that's useless? So they're going to be looking for a clinical effect size with robust data. And then if there is an effect size and a health spend saving, this won't be optional. You'll have insurance companies, not least the government through Medicare, advocating that use genetically guided healthcare, including prescribing, to reduce waste. This is why governments globally now are really pushing this space in an accelerated fashion. Because in the face of the ageing demographic and a shrinking revenue purse for the government, there's going to be needs for efficiencies in healthcare. And often technology equals more cost, less efficiency, prolonging old age when people are going through a natural end-of-life process. There's hope that this technology actually might be good for society and not an extra massive cost that's not fundable. And I'm also going to stick my neck out a little bit because I think I sort of probably can. Very few people do. And I've been thinking, do I, don't I? And I think I will stick out what I think's going to come through. And I think initially it's going to come through medico-legally. I think we're just waiting in Australia for the first medico-legal case where somebody's on a massive dose of psychotropic, there's a catastrophic event, and they say justify your prescribing. And there's various ways of doing that. It may actually be one of them is demonstrating an abnormal metabolism profile, but there'll be counter-arguments to that. This is already happening in the United States, so it might be the thin end of the wedge. I think the other thing that's going to come through in the next couple of years is multiple randomised controlled trials. So we all know evidence-based medicine too much. Good, fall back to that even in this space. Do not listen to anybody who says you have to suspend your normal evidentiary thresholds to understand genomics. Laugh them out of the room. Same evidentiary thresholds we use for any new therapeutic applies to genomics. You've got skills in that, transfer them to this, you're already 90% of the way there. So I'm going to be talking a little bit about maybe what we should do now and the evidence that's required, and then end on what's coming, which is going to be more than a technological revolution, but I think changing societal attitudes and a change in the doctor-patient relationship dynamic, which at the end of the day I think will be for the best, not for a negative outcome.